Welcome to today's session. I am Jemisha, working as Assistant Professor at Emmanuel College of Pharmacy. In this presentation, we will discuss the definition, types, etiology, pathophysiology, signs and symptoms, diagnosis, and both pharmacological and non-pharmacological management of myocardial infarction. Introduction. Myocardial infarction or MI is commonly referred to as an heart attack. It occurs when blood flow to a part of the heart muscle becomes severely reduced or completely blocked. Because of this blockage, the myocardium, which is the muscular tissue of the heart, does not receive adequate oxygen and nutrients. We know that the heart is a continuously working organ and requires a constant oxygen supply to pump blood throughout the body. When oxygen supply becomes insufficient, myocardial tissue begins to suffer from ischemia. If this ischemia continues for a prolonged period, irreversible damage or necrosis of heart muscle occurs. The most common reason for this blockage is atherosclerosis, in which fatty plaques build up in the coronary arteries. When these plaques rupture, a blood clot may form and suddenly obstruct blood flow. Myocardial infarction is considered a medical emergency because early diagnosis and treatment significantly improve survival and reduce complications. Next, anatomy of coronary circulation. The heart receives oxygenated blood through special blood vessels called the coronary arteries. These arteries originate from the ascending aorta and supply nutrients and oxygen to cardiac muscles. The first major artery is the left coronary artery, which further divides into two important branches. The first branch is the left anterior descending artery, also called the LAD. It supplies the anterior wall of the left ventricle and the interventricular septum. Blockage of this artery can lead to severe anterior wall myocardial infarction and is often called the widowmaker because of its seriousness. The second branch is the left circumflex artery, which supplies the lateral wall of the left ventricle. The second main coronary artery is the right coronary artery or RCA. It supplies the right ventricle, inferior wall of the left ventricle, and sometimes the SA and AV nodes responsible for this cardiac conduction. When any of these arteries become blocked, oxygen delivery decreases, leading to ischemia and myocardial infarction. Next, definition of myocardial infarction. Myocardial infarction can be defined as the irreversible death or necrosis of heart muscle caused by prolonged interruption of coronary blood flow. Next, epidemiology. Myocardial infarction is one of the leading causes of death worldwide and contributes significantly to cardiovascular mortality. Every year, millions of individuals suffer from myocardial infarction, making it a major public health concern. Traditionally, myocardial infarction is more common among elderly populations because aging increases the risk of atherosclerosis and vascular damage. Gender also influences risk. Men generally experience myocardial infarction earlier than women. However, after menopause, the risk increases in women due to reduced estrogen production. Nowadays, we are also observing an increasing number of young adults affected by myocardial infarction. This rise is mainly due to unhealthy lifestyle factors such as smoking, obesity, physical inactivity, poor diet, hypertension, diabetes, and stress. Next, risk factors. These include the non-modifiable risk include increasing age, male gender, family history of heart disease, and genetic predisposition. Since these factors cannot be changed, patients with these risk require close monitoring. Next, the modifiable risk factors, which are preventable and manageable. Smoking is one of the strongest risk factor because it damages blood vessels and promotes clot formation. Hypertension damages vascular walls and accelerates plaque formation. Diabetes mellitus significantly increases cardiovascular risk because prolonged high blood sugar damages blood vessels and promotes atherosclerosis. Hyperlipidemia, especially elevated LDL, contributes to plaque formation. Obesity and lack of physical activity also increase cardiac risk. Stress and excess alcohol consumption may further worsen cardiovascular outcomes. Among all these factors, controlling modifiable risk through lifestyle changes and proper medications greatly reduces the chances of myocardial infarction. Next, etiology. The most common cause is atherosclerosis, which accounts for the majority of cases. In this condition, fatty deposits accumulate inside coronary arteries and gradually narrow the blood vessels. When an unstable plaque ruptures, platelets aggregate and form a thrombus, resulting in sudden blockage of blood flow. Another important cause is coronary artery thrombosis, where blood clots obstruct coronary circulation. Some patients may experience coronary vasospasm, where sudden narrowing of coronary arteries reduces blood supply. This can occur due to smoking, cocaine use, or vasospastic disorders. Less commonly, coronary embolism may block arteries. Myocardial infarction may also occur due to increased oxygen demand, such as in severe hypertension or tachycardia, or reduced oxygen supply, as seen in severe anemia or hypoxia. Thus, myocardial infarction results from imbalance between myocardial oxygen supply and demand. Next, pathophysiology. Myocardial infarction mainly occurs because of interruption of blood supply to the myocardium. In most cases, this happens due to blockage of a coronary artery by a thrombus formed over a ruptured atherosclerotic plaque. When blood flow decreases, oxygen supply to myocardial tissue becomes insufficient. Since cardiac muscle requires continuous oxygen for ATP production, lack of oxygen quickly affects cellular metabolism. Initially, myocardial cells shift from aerobic metabolism to anaerobic metabolism, leading to accumulation of lactic acid and metabolic acidosis. ATP production decreases significantly, causing dysfunction of ion pumps. As sodium and calcium accumulate inside cells, myocardial injury increases. If blood supply is restored quickly, damage may still be reversible. However, prolonged ischemia causes irreversible necrosis of myocardial tissue. This myocardial cell death reduces cardiac contractility and may lead to serious complications such as arrhythmias, heart failure, or cardiogenic shock. Next, types of myocardial infarction. Myocardial infarction can be classified into different types based on ECG findings and underlying cause. The first type is STEMI or ST elevation myocardial infarction. This occurs when there is complete blockage of a coronary artery, causing severe ischemia and full thickness myocardial damage. The second type is non-STEMI or non-ST elevation myocardial infarction. In this condition, coronary blockage is partial, resulting in less extensive myocardial damage compared to STEMI. Another okay, First, STMI, ST elevation myocardial infarction is the most severe type of myocardial infarction. It occurs due to complete occlusion of a coronary artery, resulting in extensive myocardial ischemia. Since blood supply is completely blocked, myocardial damage progresses rapidly. On electrocardiogram, ST segment elevation is observed, which helps in rapid diagnosis. STMI is considered a medical emergency because delayed treatment significantly increases mortality. Immediate restoration of blood flow is essential. The preferred treatment is primary percutaneous coronary intervention, also called PCI. Next, non-STMI. Non-ST elevation myocardial infarction occurs when coronary artery is partial rather than complete. Because some blood flow remains, myocardial damage is generally less extensive than STEMI. However, non-STEMI still carries a significant risk and requires urgent treatment. Next, sign and symptoms. The most common symptom of myocardial infarction is chest pain. Patients usually describe the pain as crushing, squeezing, heaviness, or pressure in the chest. The pain often lasts for more than 20 minutes and may not improve with rest. Pain may radiate to left shoulder, left arm, jaw, neck, or back. Many patients also experience sweating, shortness of breath, nausea, vomiting, weakness, anxiety, and dizziness. Some patients, especially elderly individuals and diabetic patients, may present with atypical symptoms such as fatigue or breathlessness instead of severe chest pain. Next, physical signs of MI. Physical examination findings vary depending on severity of myocardial infarction. Patients may appear anxious, restless, and sweating. Cold, clammy skin is commonly observed due to sympathetic activation. Heart rate may increase, causing tachycardia, although some patients may develop bradycardia. Blood pressure can be elevated due to stress or reduced in severe infarction because of poor cardiac output. In severe cases, signs of heart failure, such as pulmonary edema, breathlessness, and cyanosis, may occur. These physical signs help assess the severity of myocardial infarction and treatment. Next, complications of myocardial infarction. Complications of myocardial infarction can occur early or late and significantly affect patient survival. One of the most common early complications is arrhythmia because damaged myocardial tissue interferes with normal electrical conduction. Ventricular fibrillation is especially dangerous and can lead to sudden cardiac death if not treated immediately. Another serious complication is cardiogenic shock, where the damaged heart cannot pump enough blood to meet body requirements. Patient may present with hypotension, poor perfusion, and organ dysfunction. Heart failure may occur due to reduced pumping ability of the myocardium. In severe cases, pulmonary edema develops, causing severe breathlessness. Late complications include ventricular aneurysm, recurrent myocardial infarction, thromboembolism, and pericarditis. Therefore, early diagnosis and treatment are important to reduce these complications. Next, diagnosis of myocardial infarction. The first important component is clinical symptoms, especially chest pain lasting more than 20 minutes, along with sweating, breathlessness, and radiation of pain. The second important tool is electrocardiography or ECG, which helps identify abnormalities in cardiac electrical activity and differentiate between STEMI and non-STEMI. Another important component is cardiac biomarkers, especially troponins, which increase in blood following myocardial injury. Next, imaging studies such as electrocardiography and coronary angiography may also be used to assess cardiac function and identify arterial blockage. Next, ECG findings in MI. Electrocardiography is one of the most important investigations in myocardial infarction because it provides rapid diagnosis. In STEMI, the characteristic finding is ST segment elevation, which indicates complete coronary artery occlusion and transmural ischemia. As myocardial damage progresses, pathological cues may develop, suggesting myocardial necrosis. T wave inversion may also be observed. In non-STEMI, ST elevation is absent. Instead, patients may show ST segment depression or T wave inversion, indicating partial ischemia. ECG not only helps in diagnosis but also determines the location of infraction and guides treatment decisions. Next, cardiac biomarkers. The most important biomarkers are troponin 1 and troponin I and T, because they are highly sensitive and specific for myocardial damage. Their levels begin to rise within a few hours after infarction and remain elevated for several days. Another biomarker is CKMB, which is useful in detecting reinfarction because its level return to normal faster than troponins. Myoglobin rises very early after myocardial injury, but is less specific because it can increase in skeletal muscle injury as well. Among these, troponins are considered the gold standard biomarker for diagnosing myocardial infarction. Next, imaging studies. Electrocardiography is commonly used to evaluate ventricular function and identify valve motion abnormalities caused by ischemia. Coronary angiography is considered one of the most important procedures because it helps visualize blocked or coronary arteries. It also helps guide treatment, especially PCI. Cardiac MRI may be used to assess myocardial viability and extent of tissue damage. CT coronary angiography can also help evaluate coronary artery disease in selected patients. These imaging methods provide important information regarding severity and management planning. Next, goals of treatment. The main treatment goal is to restore coronary blood flow as quickly as possible, relieve symptoms, and prevent complications. Initially, patients are monitored carefully with ECG and vital sign assessment. Intravenous access is established to administer medications. Oxygen may be provided in patients with low oxygen saturation. Pain management is also important because severe chest pain increases sympathetic stimulation and cardiac workload. Next, non-pharmacological management. Non-pharmacological management plays an important role in both treatment and prevention of recurrent myocardial infarction. One of the most important steps is smoking cessation, since smoking significantly increases cardiovascular risk. Patients are advised to follow a healthy diet with reduced saturated fats, cholesterol, and salt intake. Increased consumption of fruits, vegetables, and fiber is recommended. Regular physical activity and weight management help improve cardiovascular health. Stress reduction techniques such as meditation, yoga, and counseling may also be beneficial. Lifestyle modification is extremely important because medications alone are not sufficient to prevent recurrence. Next, pharmacological management. Pharmacological management aims to restore coronary blood flow, prevent clot formation, reduce cardiac workload, and prevent future cardiovascular events. Several drug classes are commonly used. Antiplatelets, Antiplatelet drugs prevent platelet aggregation and clot formation. Anticoagulants prevent extension of thrombus. Thrombolytic drugs help dissolve existing clots in selected patients. Nitrates reduce chest pain and improve blood flow. Beta blockers decrease myocardial oxygen demand by reducing heart rate. AC inhibitors improve survival and prevent cardiac remodeling. Statins reduce cholesterol levels and stabilize plaques. Usually, a combination of these medications required for optimal treatment. First, antiplatelet drugs. The most commonly used drug is aspirin, which irreversibly inhibits the COX-1 enzyme and reduces thromboxane A2 formation. This prevents platelet aggregation and clot formation. Another important group includes P2Y12 inhibitors such as clopidogrel, prasugrel, and ticagrelor. These drugs further reduce platelet activation. Dual antiplatelet therapy, usually aspirin combined with P2Y12 inhibitor, is commonly used after myocardial infarction and PCI to prevent recurrent thrombosis. These medications significantly reduce mortality and improve patient outcomes. Next, anticoagulants. Commonly used anticoagulant include unfractionated heparin, low molecular weight heparin such as enoxaparin and fondaparinux. These drugs act by interfering with the coagulation cascade and reducing fibrin clot formation. Anticoagulants are particularly useful in patients with STEMI and non-STEMI because thrombosis plays a major role in disease progression. One important point to remember is that anticoagulants increase the risk of bleeding, so patients should be monitored carefully during treatment. Next, thrombolytics. The main purpose of thrombolytic drug is to dissolve the clot blocking the coronary artery and restore blood flow to the myocardium. Commonly used thrombolytic agents include streptokinase, alteplase, and tenecteplase. These drugs work by converting plasminogen into plasmin, which breaks down fibrin and dissolves thrombin. Thrombolytics are most effective when administered early, preferably within the first few hours after symptom onset. Next, nitrates. Nitrates are mainly used to relieve chest pain in MI. The most commonly used nitrate is nitroglyceride. Nitroglycerin works by causing vasodilation, especially venodilation, which reduces venous return to the heart and decreases myocardial oxygen demand. It also improves coronary blood flow and helps relieve ischemic chest pain. Nitrates are usually given sublingually in emergency situations for rapid action. However, nitrates should be avoided in patients with severe hypotension because they can further reduce blood pressure. Next, beta blockers. Beta blockers such as metoprolol and atenolol reduce heart rate and myocardial contractility. By reducing cardiac workload, they decrease myocardial oxygen demand and help prevent recurrent ischemia and arrhythmias. Next, AC inhibitors. AC inhibitors such as enalapril and ramipril help reduce blood pressure and prevent ventricular remodeling after myocardial infarction. Cardiac remodeling refers to structural changes in the heart that may occur following myocardial damage and eventually lead to heart failure. Therefore, these medications improve survival and reduce complications in MI. Next, statins, HMG-CoA reductase inhibitors. Commonly used statins include atorvastatin and rosuvastatin. These drugs mainly lower LDL cholesterol and stabilize atherosclerotic plaque, reducing the risk of future plaque rupture and recurrent myocardial infarction. Next, revascularization therapy. One common procedure is percutaneous coronary intervention or PCI, where balloon angioplasty and stent placement are used to open blocked coronary arteries. In severe cases, coronary artery bypass grafting or CABG may be performed to restore blood supply to the myocardium. So, myocardial infarction is a serious cardiovascular emergency resulting from reduced coronary blood flow and myocardial ischemia. The most common cause is atherosclerotic plaque rupture followed by thrombus formation. Early diagnosis through clinical assessment, ECG findings, and cardiac biomarkers is essential for timely treatment. Management includes both pharmacological and non-pharmacological approaches aimed at restoring blood flow, reducing complications, and preventing reoccurrence. Lifestyle modifications, patient counseling, and adherence to therapy play a major role in improving long-term outcomes. Therefore, early recognition and prompt intervention are critical for reducing mortality and improving quality of life in MI patients. Thank you.